care coordination has been on the policy agenda for quite some time now is because, as you might know, care coordination failures are quite prevalent. And so if you look, this survey was done most recently, the Commonwealth Foundation did a 2016 survey, 11 countries. And in the US, highlighted here in red, the percentage of patients who said that they experienced a care coordination failure in the past 2 years was 35%. That percentage gets even higher when you talk about high needs patients, those who are most vulnerable in the healthcare system. Now, we care about this because there are implications of care coordination failures, right? So we know the data shows that there are poor quality outcomes for patients. We tend to see more medication errors. We see higher mortality rates. We also see the cost of care is much higher when there are care coordination gaps. So the estimates show about 25 to 45 billion in wasteful spending as a result of gaps. So not just on the policy agenda, but also for healthcare practitioners and clinicians and organizations, how do you go about reducing care coordination gaps and failures in the healthcare system? And a strategy that's receiving a lot of attention is the use of nurses as care coordinators. So when nurses take on this role, they're working at the top of their license. What they're charged with doing is managing the care process for patients, working with the patient, but also working with the rest of the care team to make sure that patients receive the care that they need at the time they need it from the right providers. Now, the theory of this is that we will see better care team performance as a result of giving nurses this role. And you can imagine there are a number of mechanisms by which this might occur. So one, there might be individual motivation, first for the care team to help patients receive the care that they need, but also for patients having this person guide them through the healthcare system. You could also imagine that we see better care team performance because there'll be task efficiencies. There won't be these gaps. Patients won't fall through the cracks. Information will be where it needs to be at the time that we need it, and so the performance will improve. And then a third mechanism that you might consider is that we might actually see better teamwork, better information processing among care team members, as you were just describing, if nurses take on this role. Now, when you look across the literature, the studies that have been done in this area, there's actually really mixed results about whether or not expanding this role for nurses has led to the outcomes that we might expect and hope for. So it leads to this question: do resulting interaction dynamics explain why some groups see no benefit? Now, we've studied this in a number of ways, but for this study, we conducted a field experiment. And in this experiment, we asked care team members to wear badges. And so these badges, if we were each wearing a badge in this room right now, you would know that the badge would record that I'm talking and all of you are listening. If someone interrupted me, it would record that. So this allows us to look at who's interacting with who and how they interact with each other. So let me tell you what we've been finding. So these are results to date. So when we look at this, so we did a field experiment, we used difference and differences to look at this. We see that something positive has happened. So nurse care coordination, when we look at the network structure within care teams, we see indications that nurses are moving into a position that would suggest that they are able to better coordinate. So if you look, a nurse was at number 3 before, she moves into the center of the network, the social network within the organization. And the nurse's centrality has been improving. Now, the thing that's been kind of interesting when we've been doing this work is when we look at how people have interacted with each other, we see some things that we think might be somewhat problematic. So we see that interruptions have increased between care team members. We see that listening appears to be going down as recorded by the badges. And we see that there's been no significant change in the equality of turn taking. And past literature done in the management work would say that better equality turn taking between nurses and physicians and other care team members would be associated with better team performance. Now you might say, well, Ingrid, that might just be a sign of more dynamic conversation. That's exactly what we want. Well, when we start to look at outcomes, and we're collecting a number of outcomes, what we start to see is that greater interruptions is associated with lower disease, chronic disease management. And we've been looking at diabetes, HbA1c levels, and we've also been looking at blood pressure. And so when there are greater interruptions taking place by clinicians, we see that that is actually not so positive for patient disease management at this point in time. So what do I think is the takeaway of this work? Well, if we see nurse care coordination happening, we see that there is a structural dynamic that takes place following this that's positive, but there may be some problematic conversational behaviors that we might need to worry about. And that's where we start to think about how managers may play a role in the way we communicate with each other in care teams. Thank you very much.